Hi, this is Audrey Gillum, and this is my clinical case presentation for PD2B. The patient presents with a chief complaint of fever and cough. He is a 5-year-old Hispanic male with his mother-father in the room. They are the primary historians. Parents are primarily Spanish speaking, so the voice interpreter is utilized for the interview and exam. The patient has a past medical history of asthma and a prior admission on October 21st of 2017 for pneumonia. He presents today to the emergency department via personal transport, complains of fever with a max temp of 103.0 Fahrenheit, vomiting, cough, chest pain, and back pain. The patient had fever last week, which was resolved for 4 days, then began last night. Parents also report cough for 1 week, non-bloody, non-bilious vomiting. 1 episode was last night and 2 episodes this morning, chest pain and back pain. Currently, he is on albuterol, BID, Singulair, and nasal spray. Reports a non-productive cough, vomiting of stomach contents, decreased appetite, and his last urination was less than 6 hours ago. Denies any congestion, no diarrhea, no headaches, no nausea, no rash, no rhinorrhea, or sore throat. He has no known drug allergies and his immunizations are up to date. With my review of systems, constitutional, positive for appetite, change, and fever. HENT, negative for congestion, rhinorrhea, and sore throat. His eyes are negative for pain, discharge, and redness. Respiratory, he is positive for cough, negative for wheezing. Cardiovascular, positive for chest pain, negative for any leg swelling. Gastrointestinal, he is positive for vomiting, negative for any abdominal distension, diarrhea, or nausea. Endocrine, negative for polyphagia and polyuria. Negative for decreased urine volume, flank pain, and hematuria. Positive for back pain, negative for joint swelling, neck pain, and neck stiffness. Negative for rash. Negative for any seizures and headaches, and negative for adenopathy. Like I said, his past medical history is asthma, and he did have the prior hospitalization in 2017 for pneumonia. He has no history of surgery. His family history, his mother and father are in good health and have no current diagnoses. He does attend kindergarten and he plays soccer. Current medications are Qvar, 40 microgram puff inhaler, 1 puff twice daily. Singulair, 4 milligrams PO every evening. Fluticasone, 2 sprays each nostril daily. And Ventolin inhaler, 2 puffs as needed, last used today at 8 a.m. Vitals, blood pressure of 121/78, pulse of 154. His temperature is 103.1 Fahrenheit temporally. Respirations are 28. His oxygen saturation is 96%. He's on room air. And weight of 22.2 kilograms. After my review of systems, my differential diagnosis would be for this patient pneumonia, possibly bronchitis, or upper respiratory infection. On the physical exam, he appears well developed. He is active and cooperative, but he does have a sickly, ill appearance, and he's not in any respiratory distress. His head is normocephalic and atraumatic. Right and left ear have tympanic membranes that are normal, and his nose is normal. His mucous membranes are moist, intention is normal, no oral pharyngeal exudate, pharynx swelling, pharynx erythema, or pharynx petechiae. His oropharynx is clear, and the pharynx is normal. Conjunctivae on his eyes are normal, lids are normal. Pupils are equal, round, and reactive to light. Right and left eye have no discharge. His neck is normal, range of motion, neck is supple, no neck adenopathy. Cardiovascular, normal rate, regular rhythm, S1, normal, S2, normal, and no murmurs heard. Pulmonary, accessory muscle usage is present. He does not have stridor, no respiratory distress. Decreased air movement is present. He has no wheezes, no rhonchi, and no rales, and he exhibits no retractions. There are diminished throughout his lung fields, diminished breath sounds. Abdominal soft bell sounds are normal. He exhibits no distension, and there's no tenderness. During this time, he begins actively vomiting on the exam. Musculoskeletal is normal range of motion. He's alert and oriented for age, and he has normal reflexes. His skin is warm and dry. Capillary refill is less than 2 seconds. No rash, and he is not diaphoretic. So after the physical exam, the plan for lab work would be a CBC with differential. Current guidelines suggest that the CBC is usually not necessary for children who will be treated as outpatients unless the CBC will help determine the need for antibiotic therapy. But since he is in the emergency department, the CBC should be obtained to determine whether he should be admitted, which is why it was done. Other labs such as sputum and blood culture should be considered on admission to requiring hospitalization for presumed bacterial community-acquired pneumonia that is moderate to severe, particularly those with complicated pneumonia, according to guidelines. Diagnostic studies that should and were ordered is a 2-view chest x-ray in the emergency department. According to guidelines as well, chest radiography is often used to diagnose pneumonia, but according to guidelines, if it is available, it is the best preferred diagnostic test. Alveolar infiltrate is more suggestive of bacterial than viral infection, especially if the infiltrate is lobar. Cultural considerations with this patient: the parents were primarily Spanish speaking and an interpreter was needed, so this could ensure all the information was understood by the parents. Other education about the patient provided is that they should continue asthma control medications in addition to any medication prescribed today. Other practice guidelines of pneumonia. According to current guidelines for treating community-acquired pneumonia, the initial antibiotic treatment is empiric because the pathogen is rarely known at the time of diagnosis. So amoxicillin 80 to 90 milligrams per kilogram per day in 2 divided doses for 7 to 10 days is first line choice for treatment. Children with pneumonia are usually febrile. They may have localized chest pain, referred pain to the abdomen, headache, or arthralgia. Pleural pain and abdominal pain may interfere with an effective cough, and these symptoms may be controlled with weight-appropriate doses of antipyretics and analgesics, such as acetaminophen or ibuprofen. So that is really emphasized that even though maybe their fever has come down, pain-wise, this will help with them having a more effective cough if their pain is controlled. The World Health Organization uses tachypnea in the presence of cough as the diagnostic criterion of pneumonia in developing countries where chest radiography is not readily available. So basically, you don't have to have a chest x-ray to diagnose pneumonia, even though it is easier to see and indicate any infiltrates with that test. So 2-view chest x-ray was done. The chest x-ray showed rounded opacity in the right upper lung, which was worrisome for a round pneumonia. And CBC results did show an elevated white blood cell count of 16.5, which is elevated and shows that there is an infection process going on. So after tests were resulted, the diagnosis for this patient would be pneumonia, fever, and vomiting. The plan in the emergency department would be ibuprofen, 10 mils, PO times 1. Excuse me. Zofran, 4 milligrams IV times 1 to help with the nausea, establishing an IV access, completing the chest x-ray, which was done, which did show an pneumonia, the CBC, which had resulted, and also giving him IV fluids of normal saline, 20 mils per kilogram IV times 2, which was 444 mils each time. Tylenol, 10 mils PO given, and an antibiotic of Rocephin IV, 1 gram, and then reassess. The ibuprofen initially was given on arrival to the emergency department. He was then later reassessed about an hour and a half later with no improvement of the 103.1 temperature, so then that's why the second dose of Tylenol was given. After IV fluids had been given and completed, the reassessment vitals showed a temperature of 100.9. His respiratory rate was 24. O2 saturation was still very good at 98% on room air. He was able to tolerate a popsicle and 4 ounces of apple juice without vomiting. At that time, he was ready to be discharged home. He was discharged home with Zofran, 4 milligrams, ODT, given PRN for nausea and vomiting, and an antibiotic of amoxicillin, 880 milligrams, which is 11 mils, prescribed for twice a day for 10 days. And then the dosing correct for his weight was given to the parents. So Tylenol would be 10 mils every 4 hours as needed for fever and pain, and then ibuprofen, 10 mils every 6 hours as needed for fever and pain. Also discussed giving fluids, rest, and supportive care. Discussed with the parents how to monitor signs and symptoms and the important signs to look for, such as chest retractions or labored breathing, and when to return to the emergency room. And also discussed rechecking with their primary care doctor in 2 days, just a follow-up appointment to see how he was improving. The parents did understand, and the interpreter was used again, and there weren't any further questions. So debriefing with my preceptor, I was able to go over the x-ray images and visually see the location of the infiltrate, which was a learning process in itself, just feeling more familiar with x-rays. The CBC was only ordered, and although it's not necessary for a diagnosis, I would have thought a CMP would be helpful in seeing further issues such as an electrolyte imbalance. And deciding whether to admit versus discharge home was discussed with my preceptor. I was leaning honestly more toward admitting the patient due to his past history of admission for a pneumonia and his asthma history. But after discussing with my preceptor the concern, the patient was perfusing adequately with an oxygen saturation of 98%, and his temperature did improve with antipyretics, and his respiratory rate was increased, but he was not in distress after interventions in the emergency department. She felt that parents exhibited a good understanding of knowledge of when to return if the symptoms did worsen, so she felt discharging the patient home would be best. Now, if this patient presented in a primary care setting, there may be limited resources available versus the emergency department, as in an x-ray or rapid blood testing so we could have lab results right away. So if I was treating the patient in a clinic setting, the assessment alone with his presentation of decreased breath sounds, high fever, tachypnea, and vomiting, I could have made a diagnosis of pneumonia and then prescribed amoxicillin just as I did in the ER, and gave education on home care. Improvements I could have made with this patient would have been more knowledge on the guidelines of pneumonia. I wasn't really up to date on those. As far as just the CBC alone would be enough to show for lab work, and just being more confident in discharging the patient home versus admitting them. All of these things will come, I'm sure, with time once I'm practicing as a nurse practitioner. Thank you.